thing which I mean by too late is once creatinine starts going up, we already believe that AKI has already set in fully. And that is why the role of all these new biomarkers and things like that to detect AKI at a very subclinical stage where some interventions may actually be beneficial. So just of interest to this audience, I think some of the new things that have come up in detecting AKI earlier is a lot of artificial intelligence also has come up, and a lot of it is actually using the electronic health data system that we have. We have patients all around us hooked up to monitors. We have so much of data that is being generated without us even realizing. All our results are on the computer. The computer can pick up kinetic GFR even before we are aware of it. So that seems to be something that is being used in low resource settings. That means where a lot of health personnel are not available to monitor very frequently, they're using it as some sort of a triage system. Where do you want to invest the doctor? So in patients who are flagged by this sort of system, maybe that may be of something of benefit. Thank you.
Thank you. And questions, we'll be happy to take. There are a few questions that have come up, but with regard to the AKI critical appraisal, do people have any questions? Others, we can quickly move to the questions that have come up. Okay, the questions that have come up is from the first study, first talk from Dr. Sushina's talk. Our main aim is to actually highlight the red flags to identify a problem so that the earlier referral can happen and we can do appropriate treatment. So the first question is actually, how accessible is renal genetic testing in Indian scenario?
Yeah, so the answer to that is, look, you're looking at accessibility or affordability, because accessibility, I don't think, is an issue in the Indian scenario. There are a lot of labs out there who do the report, and as time goes on, almost every 6 months, the price is being revised downwards. So when we started the genetic testing for a whole exome sequencing, it was something like 25,000. Now, every 6 months, when you look at the vendors list, the price is going down. So right now, the price that is being offered is around 10,000. So there is a huge cost difference. It's because there's a lot of competition out there, and it is fairly accessible to everyone. But affordability, again, over time, probably it will become affordable, but may not be affordable to a majority of Indians right now.
The second question, I'm not sure how relevant it is. Can you tell us commoner genetic diseases which have effective and affordable therapies like vitamin B6 or hyperoxaluria? Not sure.
Yeah, so if you had listened to my presentation, you would have already known. I have highlighted the actionable genes, and I've highlighted the treatments that will help you change the trajectory and the management of the disease. So there are many such treatments, even non-protective, non-specific renoprotective therapies, which has been highlighted many times by all the three speakers, like AC, ARBs, SGLT2 inhibitor. All these things can go a long way in retarding the progression of kidney disease.
Thank you. Thank you, Sushina. The next two questions are for Santosh. In patients with diabetes and proteinuria, who's on ACE and ARB, is there any benefit in adding SGLT2 inhibitor and Fineron?
The question as framed says diabetes and proteinuria with ACE and ARBs. As I said before, the combination of the two does not seem to retard the progression, although it does numerically decrease the proteinuria. So we can use it in exceptional circumstances. So I'll take it as using either ACE inhibitors or ARBs as a maximal tolerated dose. Would you want to add SGLT2 inhibitors? Actually, the evidence is now showing that you adding it is beneficial. The evidence for Fineron is not so strong because all the data so far is after at least 4 weeks of maximal doses of 4 to 8 weeks of using SGLT2 inhibitors and ACE inhibitors or ARVs. The big trial with use of Fineron for non-diabetic kidney disease is not out yet, so the data is still out. But I think by logically it should be beneficial.
Yeah. Thank you, Santosh. The second question is, for a CKD patient with metabolic acidosis who develops an allergy to sodium bicarbonate tablet, do we have alternatives?
Yeah, that's a very good question because I don't know the answer. The what I do know is it's mostly not a sodium bicarbonate, but rather than by the preparation, which may be the problem. So the easiest thing is to try and sort out, choose a different preparation and see if the allergy persists. Having said that, there is a theoretical use of an acetate preparation, not use it for correction of acidosis. So theoretically, acetate also will correct. So we can use possibly calcium acetate and try to get the same amount, but I do not know the calculation or the dosing required to correct the acidosis. In children and for patients who've got renal tubular acidosis, we use citrate-based syrups to correct the acidosis. So CKD with somebody who's got, I think these are two options which you can try. Acetate, theoretically, no practical use. Citrate, yes, it's available as syrup which you use for correction. Of bicarbonate. Okay, she says it's a bicarbonate. I've not used a bicarbonate suspension for GI intolerance. Okay.
Thank you, Santosh. The next two questions is actually for Selvin. The last one just came up. So the first one is, what do you mean by targeted release of budesonide for IgA nephropathy? Tell us how it's done.
Okay, targeted release budesonide is basically it's a capsule formulation which has a specific release in distal ileum where pair patches are concentrated. As I said before, one of the important point in the pathogenesis of IgA nephropathy is the production of galactose deficient IgA, which happens at the gut mucosa. So this formulation is a capsule formulation which is specifically released in distal ileum based on the pH dependent release. So that's why it's more specific in the pathogenesis of IgA nephropathy 1. And there is a very less systemic absorption because of the high first pass metabolism. So the systemic side effects we see secondary to corticosteroids are much lesser in budesonide compared to oral prednisolone.
The next question is, in steroid-resistant minimal change disease, can rituximab be used as the first line than cyclophosphamide?
Yeah, so steroid-resistant nephrotic syndrome, which when we come across, we always think of probably a genetic cause, in which case rituximab may not be useful. And the evidence of rituximab in steroid-resistant nephrotic syndrome as a specific thing has not been studied. We need more data on that.
Thank you, Selvin. Yeah. We'll conclude this session for the want of time. Just want to thank the Department of Medicine for taking us in for this annual conference. Just a part of the legacy. Nephrology department was actually started off by Dr. P. Koshi, who was in medicine too, and handheld two people for us, for his visionary views, who started the first dialysis in the country. And the development took, and the department took off from there. And thank you so much for remembering us and taking us a part of it. Thank you.